In this video, we will discuss in detail on blepharitis. Blepharitis is a chronic inflammatory condition of the eyelid margins and is one of the most common causes of ocular discomfort encountered in practice. A characteristic feature is the poor correlation between symptoms and clinical signs, which makes management challenging. The cause is chronic with remissions and exacerbations. Chronic blepharitis is broadly classified into anterior and posterior forms. In clinical practice, overlap is common and many patients have features of both, referred to as mixed blepharitis. Anterior blepharitis affects the area around the bases of the eyelashes. It may be staphylococcal or seborrheic in origin and is more common in patients with atopic dermatitis. Staphylococcal blepharitis is characterized by hard crests and collarettes at the base of the lashes. Long-standing disease can lead to lid margin scarring, trichiasis, and metarosis. Seborrheic blepharitis presents with greasy lid margins and soft scales. It is strongly associated with generalized seborrheic dermatitis involving the scalp and face. Posterior blepharitis is primarily due to meibomian gland dysfunction. It is more chronic and persistent condition and is commonly associated with acne rosacea. Posterior blepharitis is characterized by abnormal meibomian gland secretions, causing capping of meibomian gland orifices, plugging or pouting of gland openings, and telangiectasia of posterior lid margin. Expression may reveal thick, turbid, or toothpaste-like material, and the tear film is often oily and unstable. Demodex infestation may contribute to blepharitis. Demodex follicularum in anterior blepharitis and Demodex brevis in posterior blepharitis. Cylindrical dandruff around lash bases is a characteristic finding. Although commonly found in elderly individuals, only some develop symptoms. Symptoms are caused by tear film instability and ocular surface dysfunction. Burning, grittiness, and crusting are common, and symptoms are typically worse in the morning. Chronic blepharitis can lead to several ocular surface complications, including dry eye disease, recurrent lid infections, trichiasis and metarosis, and corneal involvement like marginal keratitis and flectonular keratoconjunctivitis. Patients should be counseled that blepharitis is a chronic condition. The goal of treatment is control of symptoms rather than cure. Long-term lid hygiene is essential. Lid hygiene forms the cornerstone of treatment. Warm compresses help soften crust and improve meibomian gland secretion, followed by mechanical lid margin cleaning. Regular and long-term compliance is essential. Topical antibiotics are useful in anterior blepharitis, while oral tetracyclines are effective in posterior disease. Short courses of low-potency steroids may be used for active inflammation. Artificial tears are also given. Adjunctive therapies include omega-3 fatty acid supplementation, tea tree oil for Demodex, and meibomian gland expression may benefit selected patients. Angular blepharitis affects the canthi and presents with fissuring and maceration due to chronic tear overflow. It is commonly caused by Moraxella lacunata. Angular blepharitis is characterized by red, scaly, fissured skin and maceration at lateral or medial canthus. It is often bilateral but may be unilateral. It may be associated with papillary or follicular conjunctivitis. Treatment focuses on topical antibiotics like chloramphenicol, bacitracin, erythromycin, and correcting tear overflow. Maintenance of lid hygiene is essential. Childhood blepharokeratoconjunctivitis is a poorly defined chronic inflammatory condition more common in Asian and Middle Eastern children. Onset is usually around 6 years of age. Frequent styes in a child should always raise suspicion of blepharokeratoconjunctivitis. The lid findings in this condition are recurrent anterior or posterior blepharitis, recurrent styes or chalasia, constant eye dripping, and photophobia. The conjunctival features include diffuse conjunctival hyperemia. Flectenellar disease is a classic associated finding. Papillary or follicular hypertrophy. Corneal involvement makes this condition visually significant. The corneal features are superficial punctate keratopathy, marginal keratitis, peripheral corneal vascularization, axial subepithelial haze, etc. The complication that can arise from this is amblyopia due to corneal scarring. Long-term control is essential to prevent corneal damage and amblyopia. Lid hygiene is essential. Topical antibiotic ointment can be applied at bedtime. Low-dose topical steroids and systemic therapy like oral erythromycin syrup for 4 to 6 weeks can be used. Recognizing key clinical signs helps differentiate the types of blepharitis and is frequently tested in postgraduate examinations. Hard scales suggest staphylococcal blepharitis. Greasy scales suggest seborrheic blepharitis. Foamy tears suggest posterior blepharitis. Cylindrical dandruff suggests Demodex. Angular blepharitis occurs at canthi, and childhood blepharokeratoconjunctivitis is characterized by lid, corneal, and conjunctival findings.